Thank you, Anna. Thank you very much. Welcome to everyone.
As always, I strongly encourage you to post your questions in the designated chat space. And as usual, you will receive a feedback survey after the seminar. Please take a moment to fill it out. Before handing over the floor to Dr. Castellucci, I'd like to introduce Rebecca to all of you. Rebecca has joined Academia this year, and she will be stepping in for me on occasion to introduce the seminars we have planned for the new year. Welcome, Rebecca. I'm so happy to have you here as well.
Good morning to everyone.
So, I won't take up any more of your time. Andrea, over to you, and see you later.
Thank you very much, Anna. Thank you very much, and good morning to all of you. Good evening, actually, or good afternoon, depending where you are. And first of all, I would like to thank Inventis for inviting me in such a webinar. And second, I would like to thank Anna Scala for her excellent job in this Inventis Academia, for all her efforts in recruiting speakers and organizing webinars like this. And of course, I would like to welcome the new entry, Rebecca, for joining this group. So my talk today will be about the minimum stimulus strategy in the diagnosis of BPPV. We will speak about the aim of the minimum stimulus strategy, that is basically the aim is to predict the diagnosis of BPPV, basically in the right position. So we will see when this kind of strategy will be used in particular, and we will see all the steps to diagnose BPPV basically from the upright position. First of all, before starting with this talk, I have to thank Professor Giacinto Asprella Ribonati, who most of you already know. He's an excellent scientist from Italy, and minimum stimulus strategy has been always among one of his workhorses, let's say. So he spent a lot of time in the study of nystagmus in patients with BPPV from the upright position, slightly bending the head backward and upward, and trying to understand which are the signs that might help clinicians to understand which kind of BPPV they have in front of them. So first of all, I have to thank him, and also because he included me and my other friends, Salvatore Martellucci and Pasquale Malara. He involved us in this kind of project, in this kind of studies, and he promoted these studies. And so this is the group that I would like to thank when I'm speaking about the minimum stimulus strategy, because we work together actually. So most of the videos that I will show will be videos that have been recorded by Professor Asprella or Dr. Salvo Martellucci and Dr. Pasquale Malara. So BPPV, all of you know that BPPV is the most common vestibular disorder, and it's due to it's characterized by brief vertigo spells triggered by head position changes with abrupt onset and rapid decrease. This is the typical canalolithiasis. And BPPV is ascribed to otoconia that dislodge from the utricular macula and go to the canal. And let's say, made some perturbation in the dynamic of the semicircular canal. So we know that if we have canalolithiasis, we have otoconia that are free to float within the canal, and the otoconia are free to float back and forth in the membranous duct of the semicircular canal that is involved, leading to paroxysmal nystagmus that will be direction changing depending on the position of the head with respect to gravity. And we also know that we might have cupulolytisis, and cupulolytisis is something slightly different from canalolithiasis, because in this condition, otoconia adhere to the cupula of the canal involved, or the involved canal. So otoconia go to overload the cupula, and this overload cupula will lead to persistent endolymphatic flows that will be direction changing according to the position of the head with respect to the gravity vector. And we also know that there might be some atypical forms like complete or incomplete canalid jam, where otoconia are partially or totally entrapped in a narrow portion of the membranous ducts, leading to spontaneous nystagmus or persistent direction fixed positional nystagmus, depending on the position they have and depending on the canal, of course, they are settling. So as you can see, BPPV, of course, is a common disorder, but it does not mean that it's an easy disorder, because we might have atypical forms, atypical places where otoconia might settle. And if we have this condition, it's nice to know from the beginning what we are going to expect when we put the patient in the positional maneuver, in the positioning test. So, of course, we might have a typical posterior canal BPPV, where otoconia are here in the ampullary arm of the posterior canal. This is the geotropic variant, because when we put the patient in the recumbent position, we will have an updated nystagmus that is typically due to a strong excitation of the posterior canal, because there's a ampullofugal flow in the posterior canal, so there's a strong excitation of the canal. But otoconia might be in the ampullary arm of the horizontal canal, leading to the apogeotropic variant, or there might be in the non-ampullary arm of the horizontal canal, leading to the geotropic variant of the horizontal canal. Otoconia might also be in a close contact with the cupula, adhere to the cupula, or in the utricular portion of the utricular side of the cupula, or in the canal side of the cupula, leading to cupulolythiasis. So we will have horizontal direction changing nystagmus that will be persistent. But we might have also atypical variants. We might have posterior canal cupulolythiasis that not so common. I would say it's not that rare, but it's not that common. I'd say it's much more common to have horizontal cupulolythiasis, horizontal canal cupulolythiasis. But we might also have the BPPV variants that are associated to positional downbeat nystagmus, like anterior canal BPPV, that it's one of the most rare variant of BPPV due to the position, the position of the otoconia that are supposed to be. In this position, the canal should be self-cleaning, so it's quite rare to have otoliths there, but it might happen. Or the most common apogeotropic variant of posterior canal BPPV, leading to a positional downbeat nystagmus. But we might have the so-called sitting up vertigo due to probably otoconia here in the short arm of the posterior canal, or close to the ampulla here in the ampullary arm of the canal, leading to atypical nystagmus, not when the patient is brought from the upright to the supine position, but when the patient is brought from the supine position to the sitting position. And we might have, of course, canalid jam and a multi-canal BPPV. So as you can see, there are a lot of variants of BPPV. So why do we have to use the minimum stimulus strategy in this patient, in the patient with BPPV? Let's try to see what is the minimum stimulus strategy and why we have to use this. So the diagnostic strategies for BPPV includes the detection of the diagnostic strategies need to aim to detect the affected gear, the first thing to understand, the involved canal, and the involved arm of the canal. Of course, every canal has an ampullary arm and non-ampullary arm, okay? And how can we how can we detect this important information? Of course, it's important because we have to treat the patient. So if we do not detect the precise location of the otoconia, we will not be able to perform the proper diagnostic maneuver. So we have the traditional approach. Traditional approach is based on the typical, the classical diagnostic maneuver, Simon maneuver and Ixel-Pike maneuver for the posterior canal, and basically the supine hydro test, also called the Painini-McClure maneuver for the horizontal canal. And this maneuver tests each semicircular canal performing movements along the plane of the canal, imparting acceleration and inertial forces, and we will see. But we might be able to use the minimum stimulus strategies that it's based on a diagnosis and treatment with the least possible amount of maneuvers, mainly with the patient in the right position. So it's basically a strategy that is based on an nystagmus-guided approach with minimally invasive tests. And the key point, of course, is the upright protocol for BPPV. So with the patient in the upright position, just slightly bending the head along the plane of the head, along the spatial plane, let's say. So let's have a quick look to the traditional approach. Traditional approach is based on positional tests, also known as diagnostic maneuvers. And diagnostic maneuvers move free-floating debris which bend the affected cupola of the semicircular canal by using gravity and by using inertial forces and centrifugal forces. And similar maneuvers have been proposed to properly diagnose each kind of BPPV, moving the patient's head along the plane of the examined semicircular canal. So let's have a look. This is the typical Dixel-Pike maneuver for the right posterior canal. You can see that the head of the patient is rotated toward the right side to align the posterior canal along the pitch plane, along the plane of the movement of the whole trunk of the head, in order to perform a maneuver that maximally move the otoconia inside the canal. So it exploits rapid movements of the whole trunk from the sitting position to the supine position with the head aligned with the involved posterior canal to impart otoconia maximal inertial forces, so achieving maximal flow velocity of the endolymph. So it exploits not just gravity, but inertial forces and centrifugal forces. And of course, this is the treatment, Epley maneuver. But we also have, and this is of course the maneuver that we have to impart to the whole trunk of the patient. We also have the supine head roll test for the horizontal canal. So you can see here, with the quick movement from the center to the right side, we'll have, depending on the position of debris, we'll have geotropic or apogeotropic nystagmus. In this case is geotropic. You can see that the patient went with the head toward the right side, and there's a right beta nystagmus that is paroxysmal. And also in this case, we had rapid movements of the head, with the head aligned with the plane of both canals from one side to the other side, and we're imparting otoconia maximal forces, maximal inertial forces, so achieving maximal flow velocity of the endolymph. So even in this case, we used gravity, inertial forces, and centrifugal forces. And how we can detect the side affected? Thanks to the Ewell second law. The Ewell second law says that ampuloidal endolymphatic flow generates stronger response than ampuloidal flow in the horizontal canal. So if we compare the amplitude and the intensity of nystagmus when we bring the head of the patient on the right side, we compare it with the nystagmus induced on the other side, we'll see which is the strongest. And if it's geotropic, the strongest is the effector side. If it's apogeotropic, the weaker is the strongest, is the effector side. So we can have the diagnosis with this maneuver. And the accurate identification of the effector side, we know that it's pivotal for an effective treatment strategies in BPPV. But sometimes we might face some problems. We might face some problems because there are papers that say that, for instance, unilateral posterior canal BPPV might sometimes account for a bilaterally positive diagnostic test. So if we have a right posterior canal BPPV and we perform a diagnostic maneuver on both sides, we might have similar nystagmus on both sides. And if we're not skilled enough to understand which is the effector side, we might have problems in understanding which is the affected side. So we might have erroneous diagnosis and improper treatment strategies for the healthy sides in case the clinicians only rely on positional nystagmus on the side randomly tested first. We need always to look at the nystagmus or the evoked nystagmus on the direction of the nystagmus. We do not need just to perform a maneuver and only rely on the presence of nystagmus. We always need to understand which is the direction of the nystagmus that was evoked in this position. But sometimes we might be in front of cases like this. We might be in cases like this, for instance, this is a horizontal canal BPPV, and sometimes it's not that easy to understand which is the strongest nystagmus, in which side is the strongest nystagmus. You see here, there was a left beta nystagmus, so it is a geotropic 4. We can say that it's a horizontal canal BPV in geotropic 4. I'm performing a supine head-roll test, and you can see that on the right side, there's a nystagmus that it's not that different. It's pretty similar to the nystagmus that I just evoked on the left side. Look again, 180 degrees on the other side. Look, there is no great difference among the two sides. So sometimes it might be difficult to understand the affected side, for instance, in these cases. So, and as more as we repeat the positioning maneuver, probably will generate a dispersion of canalids along the canal. So we reduce the piston action on the pulmonary cupola. And that's why sometimes repeating repositioning maneuver, typical repositioning maneuver, might not be enough to understand which is the affected side. Again, we always need to be sure about the type of nystagmus that we are generating, that we are evoking in a particular position. You can see here the patient has a horizontal canal BPPV, but we evoked a typical nystagmus for horizontal canal BPPV through the Dixell-Pike test. So we always need to understand which is the direction of the eyes of that nystagmus. So the diagnosis should always be based on the evoked nystagmus rather than on the positional test that has been performed. You can see here another case. This is a patient with a right posterior canal BPPV, but you can see here that the typical Dixell-Pike test does not give us any clues. It's negative. And if we put the patient in the supine head-roll test, like in this case, this is on the right side with the head tilted on 30 degrees, now we have the typical nystagmus for posterior canal BPPV, for right posterior canal BPPV. So we always need to be careful on the nystagmus. That's why the importance of a nystagmus-based approach is of pivotal importance. Another thing that is important is that if we have a patient in the acute stage of the disease, typically within the first 24 hours, 48 hours, the first days, the patient might have might have nausea, might have vomiting, might be vomiting, might have significant discomfort with this continuous positioning maneuver, diagnostic maneuver from seated to supine position. And if we do not, if we are not able to detect immediately, or with the less amount of maneuver, the affected canal, as in this case, you can see there's a right posterior canal BPPV, probably will not be able to complete the diagnostic and the repositioning maneuver, because the patient, as in this case, will need to stop, will ask us to stop and to vomit, because it's very discomfort, this kind of maneuver, from the sitting position to the supine position, and again supine to sit supine to change maneuver. And this might be true also for patients with anxious feelings, patients with anxiety-related symptoms, patients with relapsing BPPV forms, relapsing variants. They immediately know that as soon as they will go down, they will start to be vomiting and nauseous. So they will ask us, please, doctor, do the least as you can, because I don't want to suffer again. So it's for all this reason, all these factors might potentially prevent the clinician to achieve a correct diagnosis and complete the canal repositioning maneuver, in case the sign and canal affected are not correctly predicted before starting the canal repositioning maneuver. So in all these cases, we might be for all these cases, we might be happy if we can use minimum stimulus strategies. That is a nystagmus-guided approach for the diagnosis of BPPV, which aims to minimize the patient discomfort, imparting slight head rotation just enough to move free-floating particles, mainly exploiting gravity. So from the upright position, we can understand which is the canal involved, which is the site, the canal, and the R involved in posterior canal BPPV and in horizontal canal BPPV. So it has been developed in response to the need for a better tolerated and non-invasive diagnostic approach to BPPV, in particular for those patients who have a recent onset BPPV, and so active symptoms, and anxious subjects. So, like in this video, we just need to move a little bit the surface, let's say the inclination. We just need to slightly bend the head with respect to gravity, and we will probably, especially in the first days from this beginning of symptoms, we will probably lead to a slight movements of otoconia that will lead to slight endolymphatic flows, and they will lead to slight eye movements that will allow us to understand which is the canal affected, and so we'll immediately proceed with the treatment. So according to the pathophysiology of the vestibulo-ocular reflex, each cupular deflection, either exciting or inhibiting the corresponding ampullary afferents, generates the contraction of specific extraocular muscles that are coupled, leading to typical nystagmus. So we know that if we excite or inhibit a horizontal canal, we will have a horizontal nystagmus. If we excite a right posterior canal, we will have an upbeating nystagmus with right torsional nystagmus. That's basically the same nystagmus that we have if we inhibit the contralateral anterior canal, and so on. So if we have in mind this kind of scheme, we will understand what's going on in a patient with BPPV from the upright position. But we have to recall which are the axes, or the spatial axis, and the planes that are described around each axis. that we can exploit to move otoconia within the canals. Okay, so we have the pitch plane. The pitch plane is basically the sagittal plane, okay? And it's a plane that is described around an axis that goes from one ear to the other ear. So a horizontal axis called y-axis. And around this y-axis, we have the pitch plane. So if we bend the hand backward and forward along the sagittal plane, we will be able to perform movements along the pitch plane, okay? This is the first plane that we have to keep in mind. The second plane is the yaw plane. The yaw plane is basically the actual plane, that is described around an axis that goes from our chin to the top of the head, so a vertical axis called z-axis. And this plane is called the yaw plane. So each movement in this from the right to the left side and horizontal movement like this will be movements along the yaw plane. And then we have the roll plane. The roll plane is basically the coronal plane, and it's a plane described around an axis that goes from my nose to the back of the head. So a sagittal axis, let's say. And this axis is called x-axis, and the plane described around this axis is the roll plane. So movement like this with my right ear that goes toward the right shoulder, and the left ear that goes toward the left shoulder will be movements along the roll plane. So these are basically the three main axes and three main planes of the space. But we know the anatomy of the inner ear. We know that the posterior canals and anterior canals align with a plane that is tilted, that is rotated 45 degrees from this special plane. So how we can move our hands to perform movements of the head that might align with the plane of our posterior and superior canal. We can see here, for instance, if we want to make movements of the head that align maximally with the right anterior and the left posterior canal, we need to rotate our head toward the left side 45 degrees. So we will have the left posterior canal that aligns with the pitch plane and the right anterior canal that aligns with the pitch plane. So if we will bend the head forward and backward along this new plane, this new pitch plane, that's why it's a new plane. We can call it a RALP plane, right anterior and left posterior plane, okay? Because in this position, we'll only make endolymphatic movements along these two canals. And if there are otoliths inside one of these two canals, we'll probably be able to detect some movements, some nystagmus. And of course, we can do the same also in the other side for the other two canals. So for the right posterior and the left anterior canal, we can slightly bend the head, rotate the head toward the right side, and we will align the plane of the right posterior canal and of the left anterior canal with the pitch plane, with the new pitch plane. So we will do like this. So we will bend forward and backward the head along this new plane, and we'll be able to detect probably a posterior canal BPPV from that right position. And this is, of course, the LARP plane. So the minimal stimulus strategy has the key point in the upright protocol. The upright protocol is the crucial part of the minimum stimulus strategies. And basically, it includes the head pitch test. So the patient's upright position will go forward and backward along the pitch plane, okay? We will have the roll plane. We will have the upright head roll test, so slightly bending the head toward one shoulder and to the other shoulder. And we will have finally the upright RALP test and the upright LARP test. So bending the head forward and backward, with the head tilted, rotated 45 degrees left or 45 degrees right to maximally stimulate some movements of otoliths within a posterior canal or even an anterior canal. So this is our the basic algorithm that we have. And the algorithm for a minimum stimulus strategy starts with the evaluation of a pseudo-spontaneous nystagmus. We know that mainly horizontal canal BPPV might lead to pseudo-spontaneous nystagmus that looks like a spontaneous nystagmus, but as soon as the head is bent forward or backward, it will start to reverse. So first step is evaluation of pseudo-spontaneous nystagmus. If we have a horizontal pseudo-spontaneous nystagmus, we already know that probably there's a horizontal canal BPPV going on. There are also some cases of posterior canal BPPV where a slight downbeat nystagmus might be detected. They are quite rare cases. There are a few records in literature. And of course, this will immediately address us toward a diagnosis of a posterior canal BPPV. The second step is the head pitch test. So we'll bend the head forward and backward. And we will see what? If we have a horizontal nystagmus that is direction changing, okay, we will understand that there's a horizontal canal BPPV, but which is the side? Which is the arm? Geotropic, apogeotropic? We will need to perform the upright head roll test to understand if it's geotropic or if it's apogeotropic. And if we have the diagnosis, we'll start with the treatment. If we do not have a diagnosis, of course, we'll need to perform other maneuver to detect other signs that will help us to understand which is the side affected. There's a supine positioning test. So slightly bending, bringing the patient from the sitting position to the supine position, and we'll see if a slight tiny nystagmus, horizontal nystagmus, will appear. If it appears, okay, we'll know which is the canal affected, and we'll immediately proceed with the repositioning maneuver. Or if we do not have anything, we will need to perform the supine head roll test or supine head yaw test, because basically it's a movement. The Pagnini-McClure maneuver, also known as supine head roll test, basically is a test made in the roll plane, because okay, we are supine, but we are moving the head along the roll plane, not along the roll plane, along the yaw plane. Okay, so it's a supine head yaw test. It should be correctly named. Anyway, in literature, it's called supine head roll test, so we'll call it supine head roll test. But you can see how many steps we have in our hands to achieve a diagnosis of horizontal canal BPPV before going to the supine head roll test. Probably we do not need to arrive to the supine head roll test, because probably from the prime position we might have in our hands all the key signs for this kind of diagnosis. Or, and let's go to the other arm of this algorithm, we might have, with the head pitch test, we might have a vertical torsional nystagmus. And if it's a vertical torsional nystagmus, probably we are in front of a posterior canal BPPV. And if we have vertical torsional nystagmus with the head pitch test, probably we'll be able to recognize, to achieve a correct diagnosis. So we go directly with the treatment. If we do not have any nystagmus in the head pitch test for posterior canal BPPV, we might enhance the sensitivity of the head pitch test, just rotating the head 45 degrees toward one side, and go again with the upright RALP test. And if nothing happens, we'll rotate the head toward 45 degrees toward the other side to perform the LARP test. Okay, so we will probably have the diagnosis with this kind of tiny maneuver. And if we do not have the diagnosis, of course, we will need to perform the typical Dixel-Pike test or Simon maneuver to achieve the diagnosis. Of course, if we do not have any nystagmus with the head pitch test, and with the upright test, of course, we will need to bring the patient from the sitting to the supine position. Of course, we need to perform all the classical maneuver, all the traditional maneuver, if we do not detect any sign, or if we detect signs that are slightly mismatching. Okay, we will see. We will see a lot of cases. So let's have a look to the minimum stimulus strategy for horizontal canal BPPV. You know, horizontal canal BPPV might be due to canal lithiasis, geotropic or apogeotropic. Geotropic if otoliths are in the non-ampullary arm of the horizontal canal. Apogeotropic if the otoconia settle in the ampullary arm of the horizontal canal, or horizontal canal cupular lithiasis if otoconia adhere to the cupula either in the utricular side of the cupula or in the canal side of the cupula. So, which is the first step of the horizontal canal BPPV in the minimal stimulus strategy? The first step is the Pride protocol. Okay. The first step of the Pride protocol is the detection of a pseudospontaneous nystagmus. There have been a lot of papers about the detection of pseudospontaneous nystagmus, and it's true. We will find patients, I would say half patients do have slight spontaneous nystagmus if they have horizontal canal BPPV. Why? Why do they have? Because pseudospontaneous can be observed in patients with horizontal canal BPPV basically because the plane of the horizontal canal is not horizontal, is 30 degrees tilted upward from the horizontal plane. So in this position, if we put the patient in this position, there will be a slight movement of otoconia with gravity, and it will lead to an nystagmus that will go toward one side or toward the other side, depending on the position of the otoliths. And of course, due to its gravity dependency, this pseudospontaneous nystagmus usually changes direction with the head pitch test, so changes the position of the head, the angle of the head with respect to gravity, and of course with the supine head roll test. So first step, pseudospontaneous nystagmus. Second step, the head pitch test. The head pitch test has been named the Bowen-Lin test, has been named forward line, backward line. There are a lot of papers. This is just a small part of the literature on the head pitch test and on the Bowen-Lin test. A lot of scientists have dedicated papers and cases in the trying to understand which is the diagnostic role of this head pitch test or Bowen-Lin test. And actually, there are a lot of features that can be described. We can describe the direction of the nystagmus with the head pitch test. We can also describe the intensity of nystagmus, comparing the intensity of nystagmus bending the head forward and bending the head backward. So if we are able to detect a discrepancy, a difference in the intensity in one nystagmus from the other nystagmus, we'll probably be able to understand if it's a geotropic form or an apogeotropic form. But not always it's easy to perform similar movements from one side to the other side, because if we want to compare the intensity, we must be sure that the movement that we make in one direction should be the same in time, intensity, and angular movements of the movement that we perform on the other side. Because if you want to compare the intensity and the amplitude, we need to be strict with these features of the movements. And it might be difficult. It might be difficult if we do not have a video nystagmographic recording. It might be difficult if we are not skilled enough to do the proper movements. So we might need to add some other positional test. For instance, this is a patient that has a left beating nystagmus when we bring the head along the pitch plane forward, okay? And this movement, you can see here, this left beating movement reverse when we put the patient in backward. Sorry, we put the patient in backward head bending. So backward head pitch test in reverse, and it goes toward the right. And this might be due to a left horizontal canal BPPV in geotropic form, if autoconia settle in the non-apollary arm of BPPV, of the horizontal canal, because if we bring the patient forward, this autoconia will go through gravity toward the ampulla, so it will be an excitation for the horizontal canal of the left side, so we will have a left beating nystagmus. And if we do the opposite movements, autoconia will float opposite, so they will lead to ampullofocal flows inhibitory for the horizontal canal, for the left horizontal canal, so we'll have a left beating, a right beating or horizontal nystagmus. But if you look at here, the same nystagmus in forward head bending and in backward head bending at the head pitch test can be generated from an BPPV of the opposite side in the apogeotropic form. In the apogeotropic variant, you can see here if we have autoconia close to the cupula, not attached, just close to the cupula. They might be also attached, but they might be also close to the cupula. And if we forward bend the head, we will have an endolymphatic flow that goes away from the ampulla of the right side, and it will be inhibitory for the right horizontal canal. So we will have a left beating horizontal nystagmus. And if we bring the patient head backward, we will have a reversal of this nystagmus because autoconia will go toward the ampulla, so it will be excitation of the right horizontal canal. So we'll have a right beating horizontal nystagmus. So as you can see, those two types of nystagmus are the same at the head pitch test. So how we can understand if it's a geotropic horizontal BPPV or an apogeotropic horizontal BPPV? We need another test, and it will be probably enough. Which is the other test is the upright head roll test. The upright head roll test has been introduced in a few years ago by our group, by Pasquale Manara, our colleague, friend. And we first published this paper in 2019, and we, actually Pasquale, thought that probably to slightly bend the head 45 degrees, 30 degrees toward the shoulder, one shoulder, and then going on the opposite direction, probably it might be of extreme help to detect the geotropism, if it's a geotropic or apogeotropic. Let's have a look. Actually, this kind of maneuver was not introduced by Pasquale itself. There are maneuvers. These kind of maneuvers were called Bruning's maneuver, and this kind of maneuver have been used through years in the 50s, in the 60s, to understand with what kind of let's say activity might be might be due to, let's say that they were used to understand the interaction between macular and canal activity. So it was used not for BPPV, even because in the 50s and 60s, BPPV was not very known. And so they used this kind of maneuver just to understand how utricular and sacral macula could have an effect on canal activity or after canal irrigation or in other conditions. So, and if we go back to the two scenario of the beginning and we add the upright head roll test, we will understand if the patient has a geotropic horizontal BPPV or an apogeotropic horizontal BPPV. Okay, so we will immediately have a look to some examples. So this is a patient with right horizontal canal BPPV. This is Pasquale. So there was no pseudo-spontaneous nystagmus. So look, forward head bending. Look, there's a tiny right beta nystagmus. Tiny right beta nystagmus might be due to a right geotropic horizontal canal BPV or also to a left apogeotropic horizontal canal BPPV. And backward head bending nystagmus reverses, yes, and it's okay. But with the upright head roll test, we'll understand if it's a geotropic form or an apogeotropic form. Look, right head bending, you can see that there's a right beta nystagmus, and leftward head bending, there's a left beta nystagmus. So this is a right geotropic horizontal canal BPPV. Full stop. We can immediately proceed with the diagnostic maneuver, with the repositioning maneuver. Of course, we always put the patient in the supine position and we perform the supine head roll test, at least this at the beginning. But in years, we started to stop and proceed immediately to the repositioning maneuver because there was a close association between these signs and the signs that we met with the supine head roll test. Look at this patient. There was a slight left beta nystagmus in forward head bending. So it might be due to a right apogeotropic horizontal canal BPPV, but also to a left geotropic horizontal canal BPPV. So how we can tell the difference between these two types of BPPV? Of course, we put the patient in the opposite position with the backward head bending, and of course the nystagmus reverses. Now it's right beta nystagmus, but as we said, it might be due also to a left geotropic BPPV. Even if otoconia were here, they would give the same type of nystagmus. So even in this case, we can go on with the upright head roll test. An upright head roll test, so slightly bending the head toward the toward the right side, we immediately understand that there's an apogeotropic form because in this position we have a left beta nystagmus, so it should be a right apogeotropic horizontal canal BPPV. There are no other choices. And if we want to be sure that this is the correct diagnosis, we can bend the head toward the other side, and we will be sure that there's a direction change in nystagmus in the horizontal plane, and of course, this is a horizontal canal BPPV. We cannot know if it's a canal lithiasis or a cupular lithiasis. This is the only limitation of this test. We will not be sure that it's a cupular lithiasis, so persistent nystagmus, or a canal lithiasis, so paroxysmal nystagmus. For this kind of information, we'll need to perform supine head roll test. Another case, left horizontal canal BPPV in apogeotropic form, so otoconia are here in the left horizontal canal. You can see here that there's a tiny pseudo-spontaneous nystagmus that goes toward the left side. Okay, And then Professor Asprella now is putting the head of the patient forward, and you will see here that there's a right beating nystagmus, and then it might be due to a left apogeotropic BPPV, but also to a right geotropic BPPV. We cannot know just with the head bending test, with this kind of test. We cannot be sure that there's a geotropic or apogeotropic 4. Professor Aspera now is bending the head backward to be sure that there's a direction change in nystagmus, and it's direction changing because the direction now is left beating, and this is due to an excitation of the left horizontal canal, but it might be due also to an inhibition of the horizontal canal if it was a horizontal geotropic nystagmus. But if we bend the head on the roll plane toward the right side, we can see a left beating nystagmus. So this is an apogeotropic 4. And if we put the patient opposite on the left side, we can see that after a small latency, there's a direction change in nystagmus. So you can see here that there is no need for 90 degrees, but just 30 degrees, 45 degrees toward one side and toward the other side. Last case for the horizontal canal, this is a left horizontal canal BPPV in geotropic 4. So with the otoconia settling then on a pulmonary arm of the left horizontal canal. So there was a slight right beating nystagmus, pseudospontaneous nystagmus. So in forward head bending, you can see that there's a tiny left beating nystagmus. And if it's tiny left beating nystagmus, it means that probably there's a left horizontal canal BPPV in geotropic 4, but it might be also due to a right horizontal canal BPPV in apogeotropic 4, because it might be due to an excitation of the left ampullary afferents or an inhibition of the right horizontal afferents. So now Salvo will perform a backward head bending. And backward head bending will tell us that it's a direction change in nystagmus, so it's typical of BPPV, sure. And you can see here that now nystagmus reverses, is going toward the right side, because now otoconia are inhibiting the left afferents. I will rapidly go to the head roll test, but as you can see, we just need slight head bending and slight movements. We do not need big angles. We just need tiny angles. You can see 30 degrees toward one side, 30 degrees toward the other side, 30 degrees forward, 60 degrees backward, and we can have a lot of details. And we have the diagnosis, basically. So now Salvo is testing the geotropism. So bending the head toward the right, there was a right beating nystagmus. Bending the head on the roll plane toward the right side, the left side. Oh, in this case, there was no grade nystagmus, no detected nystagmus, no problem. We already have three signs, so we do not need this additional sign. It's okay. Probably now otoconia are a little bit dispersed. They were dispersed along the canal. So if the history, as I was saying, if the history of the patient is consistent with BPPV and we have all the key signs, the upright head roll test, like in this case, the upright protocol, I would say, so the head pitch test, the upright head roll test, and also the detection of the pseudonystagmus, it might not be essential to perform even the supine head roll test. We usually, at the beginning, perform every time the supine head roll test to be sure that it was typical for this kind of things. But as more as we started to use this kind of test, we saw that there was no need to perform the typical supine head roll test. The only exception is to understand if it's an apogeotropic form, if it's a cupular lithiasis or a canal lithiasis. You can see here it was clear that it was a horizontal canal BPPV of the left side in geotropic form, so we started immediately with the Buffoni maneuver for the left horizontal canal. This is another case of salvo. You can see here that a tiny pseudo-spontaneous nystagmus going toward the left side. So slightly bending the head toward the ground, so forward head bending. There was a reversal of nystagmus, and it might be due either to an inhibition of the left horizontal canal reference or an excitation of the right horizontal reference, horizontal canal reference. He now goes backward, and we have a reversal of nystagmus. A reversal of nystagmus that gives us the clue that it's a direction changing form, of course, and head roll test. 30 degrees toward the right side, there's a left beating nystagmus. Okay, this is an apogeotropic form. An apogeotropic form of the left side. Okay, I do not need to perform the supine head roll test, in particular if the patient is anxious, if the patient is nauseous, if the patient is in the first days of the onset of symptoms. So we do not need the patient to vomit to understand which is the side, even because it will not allow us to complete the treatment. So immediately, let's go to the repositioning maneuver. In this case, Salvo used a Zuma maneuver to convert this apogeotropic form in a geotropic form and to treat the patient accordingly. So I will rapidly go toward the end of this video. So as you can see, nystagmus is always going toward the right side because nystagmus needs to go away from the ampulla of the left horizontal canal. So there are continuous ampullofocal flows. And after a few times, just to understand if everything was okay, he just check if the nystagmus now is geotropic. So he achieved a switch from an apogeotropic form to a geotropic form. So there's a residual otoliths in the non-ampulary arm, and now he performs a typical Buffoni maneuver for the left horizontal canal. As I mentioned before, to achieve a correct diagnosis, we might only need 2 nystagmus. There is not always a need to have all the 4 nystagmus. Look, this patient has a right beating nystagmus in backward head bending, so it might be due to a left horizontal canal BPPV in geotropic form or a right horizontal canal BPPV in apogeotropic form. So no need to go forward. Let's go on the roll plane. So in the roll plane on the left side, there is a geotropic form. Okay, it is a left horizontal canal BPPV in geotropic form. So let's go with the Buffoni maneuver, and in fact, it gives a right horizontal beating nystagmus. And after a few minutes, Salvo will complete the Buffoni maneuver and will check again nystagmus reseated. Look here again. Look, nystagmus is almost receded completely. So just with 2 steps of the upright protocol, we understood which was the type, the canal, and the type of nystagmus, and we performed directly the repositioning maneuver. Of course, there are other steps in the minimum stimulus strategies, the sit and supine positioning test, so only bringing the patient from the upright position to the supine position to see which nystagmus appears. And of course, if it's a geotropic form, nystagmus will go on the opposite side. If it's an apogeotropic form, nystagmus will go toward the affected side. These are the so-called secondary signs of lateralization, as Dr. Califano used to name this kind of signs. But actually, if we had the chance to perform the upright protocol with the head pitch test and with the upright head roll test, usually we do not need to go to the seated supine positioning test. Of course, sometimes we do not have all the key signs in the upright position, so we need to go with the supine positioning test. There are other secondary signs of lateralization, like the neutral point in the vertical plane, the neutral point in the horizontal plane, the latency test that has been introduced recently, but usually we do not need to rely on this test if we perform comfortably the upright head roll test. So this was our first paper in 2019, only with it was a prospective preliminary study with 12 patients. And we want to compare the upright protocol with the 3-step complete battery with the upright protocol with the seated supine positioning test, and finally the supine head test, that is the supine head roll test, the Pagnini-McClure maneuver. And these are the results. The results, I'll rapidly go to the results, that the upright protocol was effective as the complete protocol in all the patients. So there was 100% of diagnostic accuracy. And we can see that pseudospontaneous nystagmus was detected in half of patients, while the head pitch test could be detected not in all the patients. But the upright head roll test was detected almost in all patients. So there was it was highly effective. And in 2020, so basically 3 years ago, we concluded a multicentric study with the upright protocol, and we collected 134 patients with horizontal canal BPPV. There are a lot of colleagues that you for sure know, like the group of Florence, like Dr. Pecci, Beatrice Giannoni, Vincenzo Marcelli from Naples, Scarpa from Naples, and other friends, Enrico Armato. So we collected a lot of patients, and in all these patients, we divided the patients according to the onset time. So the extremely acute patients, those patients who had symptoms in since a few days, patients with symptoms from 2 days and 7 days, and patients, let's say chronic patients who started to have symptoms more than 7 days before. And we performed the upright protocol, so pseudospontaneous nystagmus, head pitch test, upright head roll test. We perform in all these patients. We also measure the supine protocol. Let's say just the seated supine position, the seated supine positioning test, and the supine head roll test. So we collected also the data coming only from this supine protocol, and of course we compare all these 2 types protocol with a 3-step battery. So the complete diagnostic protocol with the upright protocol and the supine protocol together. And we found that the correct diagnosis with the upright protocol was very, very high, almost 96%, and almost complete concordance between the upright protocol and the complete diagnostic protocol including upright and supine tests. So there was no difference according to onset time. So even patients with symptoms that occurred more than 7 days before were positive to this protocol. So that protocol was effective even if either had the head pitch test or the upright head roll test, or both gave incomplete results. And this is quite interesting, because if we do not have on both positioning signs, or if we do not have signs in both backward and forward head pitch test, we can achieve the diagnosis as well. So just to conclude the minimum stimulus strategy for the horizontal canal BPPV, we can say that there's a minimum discomfort for the patient, because we do not need to rely on the supine head roll test that leads to strong nystagmus with usually strong autonomic symptoms. Only one nystagmus on both planes. So only one nystagmus on the roll plane, only one nystagmus on the pitch plane are enough for the diagnosis. Of course, it does not allow to clearly recognize the paroxysm of an nystagmus. So if we have an apogeotropic form, we'll not be sure that it's a cupulolythysis or a canalolythysis. Of course, we cannot know if it's a heavy cupula. Of course, there are some patients who do not have lithysis, but who have heavy cupula for other kind of disease. Some Meniere's disease, some patients with Meniere's disease develop heavy cupula. Some patients with migraine develop direction changing nystagmus that can be ascribed to the heavy cupula of the horizontal canal. Of course, with this kind of algorithm, we cannot know if it's a heavy cupula, cupulolythysis, or canalolythysis. We can just know if it's geotropic or apogeotropic form, and we will see. A few comments on a minimum stimulus strategy for the posterior canal BPPV. There is very few literature about this topic, at least until last year. I think in the last year probably there have been published a paper from a group, from a Spanish group of Professor Eduardo Martin Sanz about the head pitch test for the vertical canal BPPV. But there are a few papers about this, and actually they say that the head pitch test might be useful also for the posterior canal BPPV, because if we have vertical torsional nystagmus, usually if we upward bend the head, we'll have an upbeat nystagmus, and if we bend the head forward, we'll have a downbeat nystagmus, because it's basically excitation of the posterior canal when we backward head bend the head. And if we bend the head forward, we will have an inhibition of nystagmus, because an inhibition of the posterior canal, because otoliths go toward the ampulla of the posterior canal. But they both say that the head pitch test could be suited to move debris in the affected canal, so modifying the discharge activity of the posterior canal reference depending on pupillar bending. But both posterior canal lie in a plane that is approximately 45 degrees to the mid-sagittal plane. So head rotation along the pitch plane seem not to represent the most appropriate movements to shift debris longitudinally through the lumen of the posterior canal. So the use of the sole gravitational force with head bendings along a plane that it's an offset plane with respect to the posterior canal plane probably explain why some patients do not have a positive head pitch test. So why the sole head pitch test only achieve a correct diagnosis in nearly 75% of patients. I just mentioned these papers from colleagues from South America, who use actually an abbreviated distal pike maneuver, but actually it was not conceived for otoneurologist. It was just conceived for a general practitioner who want to perform some diagnostic maneuver in patients with vertigo, and to understand if it's a posterior canal, they suggested to use an abbreviated diagnostic maneuver in the seated position with a chair, and they also design a kind of repositioning maneuver, a kind of abbreviated Epley maneuver from the sitting position, but actually it was not conceived for patients, for skilled clinicians in otoneurology. So it's not a nystagmus-based approach. It was just, maneuvers for general practitioners. Let's have a look. This is a patient with right posterior canal BPPV. Here is Salvo. Salvo performing forward head bending. And in forward head bending, you can see otoconiar here. In forward head bending, nothing happens. You can see here that eyes are still. Eyes are not moving. But if he performs a backward head bending, after a few latency, you can see that a slight upbeat nystagmus, actually not that slight, a clear torsional nystagmus with right torsional component, upbeating right torsional component appears. So this is, of course, a right beating, right posterior canal BPPV. Of course, he needs to perform a diagnostic distal pike maneuver to perform consequently Epley maneuver. Of course, it might be due also to an inhibition of left anterior canal afferents. Well, of course, we know that anterior canal BPV is actually anecdotal, is rare, much more rare. So we know that if we have this kind of nystagmus and the head pitch test in the upright protocol, we'll have the chance to detect a posterior canal BPPV with it will be more likely to have a posterior canal BPPV than an anterior canal BPPV. Another case of left posterior canal BPPV. Look, left posterior canal BPPV, there is a slight downbeat nystagmus with a right torsional component. Why? Because now otoconia are going toward the ampulla, so they are inhibiting the afferents of the posterior canal. So we have a downbeat right torsional nystagmus. But if we put the patient in the head pitch test backward, we are still in the pitch plane. Now we have a left torsional component with upbeat nystagmus. Upbeat nystagmus with the left torsional component, so we have the confirmation that it's a left beating posterior canal BPV, left posterior canal BPV. And then we can proceed. If we want to keep the patient in the sitting position, we can directly proceed with the Semon maneuver that confirms the posterior canal BPPV on the left side, and we can directly proceed with the Semon maneuver, with the Semon repositioning maneuver. But sometimes we cannot have. We might not have nystagmus in head pitch test. Look at this patient. Look at this patient with the forward head bending, no nystagmus. Probably otoconia are here, but this kind of movements that is in an offset plane with respect to the posterior canal is not enough to move otoconia. I do not have details of this lady. I do not have details on the time that from the beginning of the symptoms. Probably it was not a new. It was a late onset BPPV. So I am performing an upright head roll test along the right anterior, left posterior plane, so RALP plane, nothing happens. RALP test, upright RALP test negative, but if I turn the head toward the right side and I perform the LARP test, upright LARP test, you can see now a tiny nystagmus going down beam nystagmus toward the left with torsional component, and if we go back, we can finally detect an upbeating nystagmus with right torsional component due to an excitation of the posterior canal reference, because autoconia were going away from the ampulla, like here. And now we have the confirmation with the distal pike test. Another patient, similar. In forward head bending, nothing happens. In backward head bending, in a few minutes, in a few seconds, I perform the head bending, the backward head bending, and you can see no clear nystagmus is detected. Probably autoconia. There's a slight nystagmus, but I cannot be sure to understand which is the torsional component. So I need to enhance the sensitivity of this test, rotating the head toward one side and toward the other side, so with the upright RALP test and upright RALP test. We are now testing right posterior canal and left anterior canal, and nothing happens. We're shifting the head along the right posterior and left anterior, nothing happens. Now we are shifting the head along the right anterior and left posterior, and now you can see that there's a tiny downbeat nystagmus with a right torsional component, and now there's a torsional nystagmus. There's an upbeat nystagmus with the left torsional component. Okay, now we have the diagnosis, so we can go with the repositioning maneuver for the left posterior canal BPPV. So if we have a history consistent with posterior canal BPPV, we can perform, as we said, a head pitch test. If we are able to identify the affected side of posterior canal BPPV, we can directly proceed with the repositioning maneuver. If we do not detect the affected side with the head pitch test, we can perform movements along the plane of the posterior canal with the upright RALP and upright LARP test. So if we identify the affected canal, we can directly go through the repositioning maneuver. If we do not identify, of course, we need to perform both distal pike tests, of course. And this is the PRIDE protocol for the posterior canal BPPV. And this is our paper 2 years ago. It was a prospective multicentric study. We included other colleagues from Italy, and also in this case, we divided the cohorts in 3 groups: the early stage BPPV, the subacute BPPV, when the symptoms from 2 days to 7 days, and let's say the chronic stage of BPPV, when the patients already had symptoms that began more than 7 days before. And we saw that the head pitch test elicited nystagmus in 92 cases, in 40 cases in both head bendings, while in 47 cases only in backward position. Of course, in backward position, it's much more common to have this kind of nystagmus because it leads to an excitation of nystagmus. So nystagmus is stronger, so it's much more easy to detect stronger nystagmus due to an excitation of posterior canal. And the head pitch test alone predicted lacoric diagnosis more or less in 75%. So we achieved the same percentage of the literature. But if we add the upright RALP and the upright RALP tests, we were able to identify the affected site in additional 13 cases. in additional 13 cases. So it was very interesting because the upright protocol with this additional upright LARP test allowed a COVID diagnosis in 87% of cases. The important thing is that the diagnostic sensitivity was 100% in patients presenting within 7 days from the symptoms onset, while it reduced less than 79% of patients with the patient that were examined later than 7 days. So in this case, time was important. Time was an important factor. And we know that, of course, the intensity of positional nystagmus in BPPV depends on several factors like the critical mass and the position of canalids. And since the otoconia mass is thought to be larger and settled in the central part of the canal in the first stage of the disease, cupular deflection should be wider in this condition. So this accounts for stronger vertical spells and stronger nystagmus. Okay. So accordingly, diagnostic tests based on otoconial gravitations along the affected canals, due to these slight hand movements that only exploit gravity, are likely more sensitive in the acute stage of the disease, and mainly if hand movements are closely aligned with the canal plane. So in the first days of the disease, when the minimum stimulus strategy is very, very, very useful for us. Right in this period, we might have the chance to have higher chance to detect signs of the canal affected, and spare the patient useless supine to positioning. And again, supine to recumbent to supine, seat to supine, and again, and disabling symptoms, let's say. So therefore, the impairment of the upright protocol sensitive over time may be related to reduced cupular bendings and weakness time was due to a progressive reduction of the otoconial mass and otoconial dispersion along the membranous duct. Of course, this is much more easy to occur as more as time passes from the beginning of symptoms. You can see here a patient with a long-lasting right posterior canal BPPV. Of course, we are doing all upright tests to understand if there's something going on, but as you'll see, there is no detectable nystagmus, and this is not because she does not have BPPV. This is not because I'm not performing the maneuver in the correct plane, because as you can see here, I'm performing the maneuver along the left posterior, right anterior, so the RAL plane, and nothing happens. Nothing happens in both positions, in both backward and forward head bending. And you'll see that also in the LARP, left anterior, right posterior plane, nothing will happen. So it means that probably otoconia are a little bit dispersed along the canal, and they do not achieve the critical mass to lead to endolymphatic flows that lead to detectable nystagmus. And this is a matter of time, of course. So this kind of treatment, this kind of algorithm is is highly sensitive in the first stage of the disease, in particular for the posterior canal. As I showed you, according to our data, there is no matter of time for horizontal canal. Probably horizontal canal. In horizontal canal, otoconia are more free to move than posterior canal, probably. But as you can see here, there is no nystagmus on a trilateral test. But if we perform a diagnostic maneuver, the traditional diagnostic maneuver, this is a distal pine maneuver, we can see here that there's a typical right posterior canal BPPV. So this is important thing to remember. This upright hydral test using just the upright protocol using only gravity is highly effective in the first stage of the disease. Another important thing to remember is that if we use this test, we might be in front of a typical case. Look, this girl with this lady with right posterior canal BPPV. There is nothing going on in head pitch test with the head pitch test. Forward and backward head bending. Now we'll go to with the upright RALP test. So nothing is going on the forward bending. Nothing is going on in the backward head bending along the plane of the left posterior canal. But if we go through the upright LARP test, we can see a tiny downbeat nystagmus in forward head bending, like an inhibition of the right posterior afferents, slides. Actually, it was very slight, but now it's very clear. With backward head bending, you can see here a strong nystagmus due to an excitation of the posterior canal reference, so it's typical posterior canal BPPV. And sometimes, if we directly proceed with the diagnostic maneuver, the Dixell-Pike maneuver, when we had this strong nystagmus in the head pitch test, in the head protocol, you can see here that the patient had a strong nystagmus. So in this case, she was nearly to vomit as well. But if we had this kind of strong nystagmus, we might not detect a typical paroxysmal nystagmus, ambient paroxysmal nystagmus, probably because otoconia already went toward the utricular, probably they are already in the non-ampullary arm, so we had a tiny downbeat nystagmus. This is something that I would like to tell you, because sometimes when we use this kind of protocol, we might not be able to detect with the typical diagnostic maneuver the typical upbeat torsional nystagmus. So in posterior canal BPPV, minimum stimulus strategy leads to minimum discomfort for the patients with a very high sensitivity, mainly in the acute stage. So a few words for the multi-canal BPPV. Look at these patients, and this patient with trauma, post-traumatic patient. Look, backward head bending with the LARP at the upright RALP test. Upbeat nystagmus with the right torsional component, so there's for sure a right posterior canal BPPV. Look, now Pasquale goes with the upright RALP test along the left posterior canal, and look, there's also a upbeat nystagmus with the left torsional component, so probably, actually for sure, this lady has a multi-canal BPPV. And actually is very useful to know from the beginning if we have just one canal affected or both canal affected, because we will need to understand if we perform diagnostic maneuver and repositioning maneuver, we are happy to understand if there are more than one canal affected, because we will be able to better clarify the nystagmus that we will face when we perform a repositioning maneuver. Look, this is another lady with multi-canal BPPV. Look, in upward head bending with the head pitch test, there's probably a tiny upbeat nystagmus with the left torsional component, probably. It's not easy to understand. But probably I understood that there's something going wrong here. Then we confirm that there's a left posterior canal BPPV with the upright RALP test. Okay, now tiny downbeat nystagmus with the right torsional component because it's inhibiting the left posterior canal reference. Now there's a upbeat nystagmus with left torsional component because now we are exciting. Now otoconia are going away from the posterior canal afferent cupula, so they're exciting the posterior canal, the left posterior canal. So we confirm that there's a posterior canal BPPV. Okay. And we perform an upright RALP test. And then we want to check also the other side. And look, there's a tiny downbeat nystagmus with the left torsional component. And now there's a stronger nystagmus, upbeat nystagmus with right torsional component. So we are in front of a bilateral posterior canal BPPV. And it's important to know if this lady has a bilateral posterior canal BPPV because probably it's better to perform Semon maneuver. Semon maneuver only exploit the plane of the affected canal. So if we want to treat the right posterior canal without moving otoconia on the left posterior canal, it's better to use Semon maneuver because Semon maneuver is only through the plane of the right posterior canal, of the posterior canal affected. If we used A-plane maneuver, we probably move also the otoconia on the other side. And look, now there's a liberatory nystagmus. So we're moving only otoconia in the right posterior canal. Nothing is going on the left posterior canal, and it's good because she has both posterior canal affected. So the next time we will perform a Semon maneuver on the other side. We will check the right side and we'll perform also Semon maneuver in the left side. So this is good because we are just moving otoconia in the posterior canal that we're testing. This is another lady with multicanal BPPV. Let's have a look. Downward, forward head pitch test. Probably there's a tiny left beta nystagmus, probably. Head pitch test backward, there's a right beta nystagmus, so probably there's a horizontal canal BPPV in this lady. Probably it might be left horizontal canal BPPV or right horizontal canal BPPV, left in geotropic form or right in apogeotropic form. Okay, let's have a look in upright head roll test. Upright head roll test gives, along the roll plane, gives there was a tiny geotropic nystagmus, so probably there's a left geotropic BPPV. Left geotropic horizontal canal BPPV. But I want to be sure that she does not have posterior canal BPPV, but actually she has. Look, there's a tiny downbeat nystagmus with right torsional components, and here there's a stronger upbeat nystagmus with left beating torsional components. So probably she has horizontal canal and posterior canal BPPV on the same side. I will rapidly go with the diagnostic test. We said before that she likely had left beating horizontal canal BPPV in geotropic form. In fact, she has a horizontal geotropic BPPV, and now I'm just performing some maneuver to be sure that it was a left horizontal BPPV. And actually she has both sides geotropic horizontal canal, but as you could see, there was not a great difference between the right and the left side. So the upright protocol was very important, was highly important to understand that there was a left horizontal canal BPPV. And now she also, we also have the confirmation that she has also left posterior canal BPPV. The last case, it was an interesting case because this man had a typical horizontal canal BPPV. Look, there's a strong horizontal nystagmus toward the left, so probably there's a right horizontal canal BPPV in geotropic form or a left horizontal canal BPPV in apogeotropic form. We will see later. Okay. So it reverses, so right geotropic or left apogeotropic. So we can perform a head upright head roll test, and you can see here, okay, it's geotropic. It's geotropic. We have the confirmation here that it's geotropic. Great. So we do not need to perform supine head roll test. Okay. So this person, this man has a geotropic horizontal canal BPPV of the right side. So this is the cartoon of what we made to understand which is the diagnosis. So we perform immediately the Guffoni maneuver. But look what happens. Look what happens. During Guffoni maneuver, probably I made some mistakes with the planes, and we can see here some torsional component, sudden torsional component. Look, the patient is, look, there is a torsional component over the right. So probably I made some mistakes during the maneuver. This is what I imagine. During the maneuver, I made these mistakes. And probably otoconia fell here in the short arm of the posterior canal. And look, I use the upright head roll test to have a confirmation that otoconia went in the short arm of the right posterior canal. So probably they attached to the utricular side of the posterior canal ampulla. So they did not, they did not fall in the utricular macula, but they went away. They went toward the posterior canal cupula of the same side, of course. And later I confirmed that it's a cupulolithiasis of the posterior canal. But it was not from the beginning. It was iatrogenic. It was due to my incorrect diagnostic maneuver, incorrect treatment strategy. And you can see here a persistent upbeat right torsional nystagmus consistent with right posterior canal BPPV. So I rapidly go to the ending of this talk. I would like to thank, of course, Professor Asprella, but in particular my friends Salvo Martellucci and Pasquale Malara, who made this kind of talk with me, I would say. And I would like to thank all of you for your kind attention. And I will immediately go to read the questions.